Hello doctors, it's good to see you all back in our dialogue video series, and this time specifically I've come with the topic of first trimester anatomical checkpoints. This is Dr.deepthi Jammi, consultant fetal medicine specialist at Jammi Scans, Chennai. And why this topic? Because specifically in this topic, what I'm going to talk to you about 4 common things. It's going to be practically very useful for you, because the first thing what I'm going to talk is about the most common anomalies that we see. Not all, but very common anomalies which we see, because that's one of the anomalies. What we're going to talk is neural tube defect, because we need to understand the importance of an NT and an IT image. How do we identify NTDs? So that's number 1. Number 2, many a times we do get referrals when we say a normal anatomy, a normal physiological fetal anatomy mistaken as an anomaly. So then that also we need to understand, because we need to reassure the patient that this is normal. As the baby grows, it's going to be perfectly fine, right? So that the 2 things are omphalocele and also rhomboencephalon on the 4th ventricle. So let me take you through those 2 cases. Last but not the least, when you might have encountered a case of megacystis or distended bladder in the fetus in 12 weeks. And here we're going to talk about a baby which we have had follow, and we have discussed how to manage those babies. So I think the next 4 to 5 minutes is going to be fully practical base points on how to use these diagnoses or how to prognosticate and follow these babies up. So the first thing, as I told you that we're going to talk about neural tube defect, it is very important that earlier days when we knew that we were talking about those lemon sign and banana sign and open neural tube defects in fetuses, they're all diagnosed only by 5th month, or say without facilities they've been diagnosed only in late 2nd trimester or even sometimes after delivery. But then we've come to an era of advanced imaging technologies wherein we are able to diagnose such fetuses as early as 12 weeks. And what makes us diagnose such fetuses? We need to know, isn't it? That's the first point. So the first point, if you can see here, this is a normal routine primary gravid who came to us 12-weeker with a good crown rump length. We're able to image, but then over here, or when you take the NT section, the NT is down, looks normal. There is also something called IT. IT is called intracranial translucency. It's been there for more than a decade now. We started seeing IT in probably say 2011 or 12 is when it started. So it's more than 10 years now. If you identify that the intracranial translucency or that space is obliterated because of the posterior fossa, then when it is obliterated, you also have to look at the spinal defect. And what is it? That's the same thing what you see. See, if you can actually closely see, there's a scalloping of the frontal bones, and there's the banana sign which you see in the cerebellum, no? That's because of the posterior fossa getting obliterated. That's the same thing what we are resonating in the first trimester. But what we need to understand over here, the specific point is, if you don't visualize an intracranial translucency in the NT scan, and if you can detect a defect in the spinal cord, then your accuracy, that is, you are highly specific to identify an open tubal defect. That is close to 99%. But can you identify ONTD in all fetuses at 12 weeks? No. That's close to around 50 to 53% of the time you might tend to miss an ONTD even though it is present in the fetus. So those fetuses you will be able to probably see it at 18 or 19 or 20 weeks. So if you see an absent IT along with a spinal defect, you are almost 100% close to 99.7% sure that it is an ONTD. And what is that IT? What I was saying, and how do you identify? This is a normal NT image where you can see over here, that's the falx. This is the brain, midbrain followed the black marker, that hypoechoic space is the brain stem. Beneath that you will be able to see an intracranial translucency, that's the space over here. Beneath that IT is the cisterna magna, and there you have the NT. So what you need to see in an NT image, you need to have a circular one, that's the midbrain. Then you have 1, 2 and 3. So you will have 3 spaces, anechoic spaces. Between those 2 you will have 2 lines. Those are those 3 spaces and 2 lines, right? So what happens if you don't have an IT, obliterated IT? That means then you will have only two hypoanechoic spaces where you have only one single line. So that's when you go and check on the spinal cord very clearly. So it's very important that this is one of the most commonest thing, and it saves a lot of time and energy for the obstetrician and also for the patient, because these babies, we all know that open neural tube defect babies don't do that well post delivery, but it's important that we give them that close-up call during the first trimester to decide on whether to continue or not. Listen, okay, apart from that, now next let's come to the more interesting part. So we all know that there is something called physiological gut herniation, and what is the cutoff is what we need to know. Even though recently we get babies were referred as query omphalocele, where the baby was only around 3.5 centimeters. So why I have put it is that yes, you could probably give the baby 1 week or 10 days time to grow. The cutoff of physiological omphalocele is 45 millimeter. Here, if you can see here 3.5 centimeters, you can actually see that the small bowel or gut herniation is there. Whereas when you called her back at around 12 to 13 weeks, over here that the insertion site is beautifully closed, the NT is normal, IT is seen, and the baby is perfectly normal. So the cutoff of physiological omphalocele is 45 millimeter. Okay, one more common thing, the cystic structure in the fetal brain, and that was specifically when you screen these fetuses, early pregnancy scan at 9 weeks, 8 to 9 weeks is when they get a measurable CRL, and that time when you see a cystic structure in the fetal brain, that is nothing but the developing fourth ventricle or rhombencephalon. This is not abnormal at all. This is a perfectly NT image where the fetus is normal, and that's a normal developing fourth ventricle. So we have seen 3 practical points. The last but not the least, the last one I would like to finish up with a case scenario, that she's a second gravida, previous absolutely normal child. Here we are going to talk about, as I told you, a case of distended bladder. A fetus, when she came to us for second opinion at 12 weeks with distended bladder, rest of the things were absolutely normal. The kidneys were also normal. 3 vessel cord, you can see a bladder which is slightly prominent. So then what is the normal level of bladder? The longitudinal diameter, if you can see, should be less than 7 millimeter. So then what do we do? Longitudinal measurement is 8. Then how do you counsel those couple? 2 important things. The first thing, when you see a distended bladder, the first thing what you need to know is the measurement. If the measurement is more than 7 millimeter or within 15 millimeter, then you think more in favor of chromosomal abnormalities. That's very important, but definitely not always. At least 25% of aneuploidy is what we think when the measurement is between 7 to 15 millimeter. But what happens if the measurement is above 15 millimeter? Then it points more in favor of a lower urinary tract obstruction. So you would ask them to get back at 16 to 17 weeks to see if the kidney is dilated or hydronephrotic. So that crucial point is very important, because that's what paves the way for our counseling. So we reported as distended bladder. Yes, Leica and fetal kidney is normal. We did advise them for a CVS or amnio, but they went ahead for first trimester screening and they came back with this report. So this first trimester screening report was normal. They were more than satisfied. They were not willing to go because they felt that, doctor, I have one healthy baby boy and my screening report is negative. So let's follow up. At 16 to 18 weeks, you would be seeing that it's like seeing a normal bladder at all. At 8 millimeter, it didn't distend at all. The kidneys were perfectly normal. Followed up till late term gestation at 36-37 weeks, perfectly normal bladder and kidneys. Yes, this was definitely a good baby, follow up done and beautifully recovered from the distended bladder. But what are the key points that we need to monitor in this is that how we counsel the couple, because this baby is now around 3 to 4 years old, doing absolutely fine, had a full term normal vaginal delivery. The reason why I put up this case, it's all about counseling, because once we know what is the normal cutoff, we did talk to them about invasive testing for the chromosomal abnormalities. Yes, all went well. Baby is healthy, but this does not happen always, isn't it? So what we need to do, we need to have a definite conveying talk with the obstetrician. The geneticist plays a major crucial role in it. Do we definitely have to talk about both pre and post test counseling? Do we opt for NIPT in such cases is a question, because we are not thinking only about Down syndrome, we are also worried about other chromosomal markers. So we would probably prefer an amnio or a CVS. Preconception counseling is very important, not just for megacystis. We're talking about neural tube defect, the correct, accurate, adequate by BMI for the mother before she conceives again, and also preconception folic acid of 5 milligram. So I hope that this video on anatomical checkpoints during the first trimester is helpful to you. For more and more videos, we have taken common 3 to 4 scenarios in this anatomical checklist. So more videos on first trimester coming all your way. This is Dr. Deepthi Jammi. I'll be more than happy to receive your feedback and more topic suggestions from you all. Until then, take care. See you also in another video.